Good evening, folks. Thank you for attending our September Amended Hearts meeting. Please be advised that we are recording, and that your likeness and or your voice may be used in our social media presentation. If you do not want to be recorded or you do not want your likeness shown, please let the moderator know, and we will act accordingly. But in the meantime, okay, thank you. Let's enjoy our speaker. Karen, I'll let you introduce her. Thank you.
Tonight, our speaker is a return speaker. She actually spoke for us last year on heart failure and cardiac warning signs. We are bringing you Maddie Verna tonight. She's an experienced cardiovascular ICU nurse at MedStar Washington Hospital Center. She has a specialization in nursing education. She loves to educate her patients and new nurses about everything related to the heart. Outside of work, she enjoys running, baking, and caring for her beautiful one-year-old daughter. So welcome, Maddie. We're happy you're here.
All right. Well, as Karen so nicely introduced tonight, we are talking about pacemakers. So I know in the introductions, we heard maybe a couple members of the group have pacemakers, so people have personal experiences. Tonight, I'm going to talk a little bit about the background of the electrical system of the heart, and then we're going to move into talking about how pacemakers work, a little bit about ICDs or implantable cardioverter defibrillators, which can be a part of a pacemaker. And then we're going to go over some things about how the pacemaker is inserted and done by the doctor, as well as just some fun like myth busting at the end that people with pacemakers might know the answers to a couple of my like trivia questions. So without further ado, we're going to move forward. So first, we're going to talk a little bit about the cardiac conduction system. And so the heart has both structures and the electrical side. And so right now we're talking about the electricity and how it moves through the heart. So you'll see on the top left of the screen, the first thing that's noted is what's called the sinus node. And the sinus node is the natural pacemaker of the heart. As you see on the slide I wrote, the normal heart rate for most individuals is between 60 and 100 beats per minute. Now, there can be certain things like athletic training and younger individuals may have a lower resting heart rate. And then things like, for example, like if someone's at a heart transplant, there are things that related to that may make them have a heart rate that's resting above that. But for the majority of people, a normal heart rate when they're at rest, just sitting, relaxing, is between 60 and 100 beats per minute. This node, that's what controls that. So typically, the heart makes its electricity move through in a very sequential, predictable way. And so you see it moves from the sinus node, following those blue arrows across both of the atria, which are the top chambers of the heart, to what's called the atrioventricular node, or you might hear it referred to it also as the AV node. That really is an important point in the conduction system because it's the transfer point of electricity between the top chambers of the heart, the atria, and the bottom chambers of the heart, the ventricles. And so then the electrical impulse moves down along this AV node to what's called the bundle of His, the bundle branches, which are shown at the bottom, and then not labeled here, but the final step of this cardiac conduction system is something called the Purkinje fibers.
I
All
don't
that
know.
to say,
It's about
I'm here, sorry. All that to say,
pacemakers.
it moves through in a very sequential and predictable pattern most of the time. And the way that we kind of determine how this is working, if you go see your doctor or come in to get an EKG test done, would be to do what's called an electrocardiogram or an EKG. And so that's the test where the technician or the nurse will put those stickies on your chest, and they help relay a squiggly line that tells us about how the heart's functioning. And so this picture is just showing on the top what a normal EKG tracing is. So if anybody's ever had one, then you may recognize this as like how a heartbeat is shown or what showed up after the test. But each portion of that squiggly line connects to a very particular part in that cardiac conduction cycle. And that cycle continues over and over and over again for most people, 60 to 100 times a minute, thousands of times per day. In this cycle. And so when we're trying to diagnose what's going on with the heart, if there's any abnormality in this conduction system or if it's functioning normally, we're going to look at this sequence of waves. So they're named P, Q, R, S, and T, and the doctor or the nurse would take a look at it and determine what exactly is going on based on what's happening in each of these waves because they correlate to a specific part of the heart. So we're going to talk a little bit about why someone would need a pacemaker. So the main reason that someone would need a pacemaker is this big, broad umbrella term called an arrhythmia. And so arrhythmias can be a whole wide variety host of things. I know when I was a new nurse starting at the hospital, we had an entire, I think it was like a 3 or 4 hour class just devoted to how to recognize what we call these arrhythmias or abnormal heart rhythms on these EKG tracings. So really there's a lot of information to unpack in that. And it's not just confined to reasons that people would need a pacemaker, but certain types of arrhythmias, which are called bradyarrhythmias, the prefix Brady in. So it's something that slows the heart rate outside of the normal range. So we talked on the first slide about how normal heart rate is between 60 and 100, but these quote Brady dysrhythmias are things that where the heart rate would fall below 60 beats per minute. Like I said before, not everybody's heart rate being below 60 beats per minute is always a problem. There's actually something called sinus bradycardia, which originates from that sinoatrial node or the SA node that we've talked about as the normal heart pacemaker. That is a normal conduction, so everything moves through in that way that I explained, but for whatever reason, the heart rate is less than 60 beats per minute. For some people, this can be normal. Like I said, very well-conditioned athletes or young people may have a resting heart rate in possibly even like the 50s, sometimes even 40s. I think I heard one time that Michael Phelps's resting heart rate was like in the high 30s, but I don't know. I can't substantiate that. So, point being, there is normal variance where someone may have a slow heart rate, but then there's also something called heart blocks, which are problematic nearly all of the time. There are different parts, and basically, if we go back to that slide where we talked about the cardiac conduction system, if you think about a lack of communication at any of these points, so for example, if the signal is not getting properly from the sinus node to the atrioventricular node, or maybe there's some slowing, maybe it gets through some of the time, but not all the time, or maybe there's no communication at all. That's kind of what we're talking about with the heart block. So there's some problem where things are not talking to one another in this conduction system. And so that can be problematic because in that case, the top and bottom chambers of the heart aren't working together efficiently all the time. And the heart rate can go so slow that it can cause other problems and cause people to become symptomatic, which we'll talk about what some of those symptoms are on a following slide. These heart blocks are diagnosed by an EKG. So you see on the right-hand side of the slide on the bottom, that's an example of what no communication between the top and bottom chambers of the heart would look to your doctor or nurse on a EKG. And like I said, it produces a slow heart rate. And the reason for that is that our bodies are actually super smart and they have a backup system that is built in. So that normal heart pacemaker, the SA node that we talked about in the couple slides back, is kind of set at a rate of 60 to 100. If that fails for whatever reason, it's not working, there's not communication between it and the rest of the conduction system, the next part down, the atrioventricular node is going to take over and it's going to step up to the task and it'll say, all right, but it can only beat most times for most people somewhere between 40 and 60 beats per minute. And so for most people, that heart rate's a little bit too slow to keep doing your normal activities and feel, right. They're even lower in the heart if the atrioventricular systems beyond that, but usually most people would, feel bad before then. All that to say, when there's not communication between the sinus node and the atrioventricular node, then that frequently will produce a slow heart rate that for most people, not everyone, most people, they're going to start feeling symptoms. So let's move into talking about symptoms. So people who have these arrhythmias may notice fainting episodes or passing out, dizziness or lightheadedness, palpitations, like a sensation of your heart pounding in your chest. People may feel like confused or just foggy. They can, or just super fatigued. Shortness of breath is also common. And then all of these are kind of a result of the heart being unable to pump blood that is enough to meet the body's needs. In other words, we refer to that as heart failure. So these are some of the things that people may feel when they have the slow heart rates that possibly need to be corrected by a pacemaker. There's also multiple causes for what causes these arrhythmias. It's not the same cause for everybody. One major cause can be coronary artery disease or plaque buildup in the arteries. Congenital heart defects, which are problems in the structure, so problems maybe with the valves in the heart that are often present at birth. Inherited genetic abnormalities, so not problems with the structure of the heart, but problems with the conduction system. They're like, if you hear about like maybe young athletes who have like risk of like sudden cardiac death that's inherited genetically, that's kind of like what it's talking about. And then diseases of the heart muscle tissue, so what we call cardiomyopathies. Some medications can alter the heart's normal rhythm. So a lot of those antiarrhythmics that are meant to correct arrhythmias can actually cause arrhythmias as well. And your doctor would be monitoring for that. And then also just aging of the heart muscle can cause arrhythmias. Now, with all that talk about kind of how it normally functions, what leads someone to need one, and then now we're going to talk a little bit about how pacemakers actually work. So this is a picture of how a pacemaker would look when it's situated inside the body. On the right-hand side of the screen there, you see the pacemaker generator, what's referred to as the pacemaker there. And that basically is the brains and the battery of the pacemaker. So that's what is producing the electrical charge to make the heart beat. And then also it is getting information from the heart itself. The way that it does that is through the leads that you see are threaded through a vein to the right side of the heart. And so what the pacemaker does is it will be set to make the heart beat a certain number of times per minute. Some of the settings vary, and we'll get into that. But that's mostly what it does, is make sure that heart keeps beating regardless of what, arrhythmia or rhythm problem exists, and make sure that the heart beats enough times per minute to make sure that someone doesn't feel dizzy or pass out or have issues related to the arrhythmia. This is a little picture. I just wanted to show you guys the size of how big a pacemaker is. It fits in the palm of a hand. It's relatively thin and light. And that is what is that battery in the brain of the pacemaker. So the device works by creating an electrical discharge from the generator, which is that piece we just looked at in the person's hand, and it stimulates the heart muscle to create a heartbeat. The generator contains a small computer processor, and it can be programmed to set the pacemaker rate, a pacing pattern, energy output, and other parameters like certain therapy and stuff that it might do, and that would be set by your doctor. And now today in modern day pacemakers, the medical team can monitor how well the pacemaker is working through a remote device. Typically, this device is sent home with you when you first get your pacemaker, and then the doctor's office will determine how often they want you to maybe send information to them, and it will upload it to a system that they can usually see remotely. I just wanted to show you a little bit of what your doctor would see and a difference between a normal rhythm and a pacemaker rhythm. So the top rhythm is kind of that normal squiggly heartbeat that we know that has kind of like the first P wave, and then it has that QRS complex, the big spike, and then what we call the T wave after it. And that's kind of how the heart rhythm looks normally. What I want you to notice on the bottom one is that there are two really big fat spikes before the heartbeat wave. And that actually is what is showing on the EKG of the pacemaker function. So those spikes are showing the pacemaker delivering that little energy to the heart to make it beat. And so that's what, if you had a pacemaker and went in to go get an EKG test done, what it might look like as opposed to the normal rhythm that's up top. There are also a couple different types of pacemakers, and depending on what rhythm problem someone would have, the heart rhythm doctor, which they're specialized, they're called electrophysiologists. So they are doctors who've completed not only their normal residency, so they're training after medical school, but they've also completed a fellowship in cardiology, which is 3 years. And then they go additionally to do electrophysiology. So they're really, really, really very specialized heart rhythm doctors that focus on pacemakers, rhythm problems, and the ICDs that we talk about as well. So there are a couple different types of pacemakers that they may choose, and they would choose this based on the rhythm problem that someone has. So there's a single chamber pacemaker that has one lead electrical wire that is either in the upper or lower chamber of the heart. There's something called a dual chamber pacemaker that uses one lead in the upper chamber and one in the lower chamber. This can help to make sure that the heart is synchronized well. And then there's also something called a biventricular pacemaker that has three leads. So one that sits in the top right chamber of the heart, the right atrium, one that sits in the bottom right chamber, the right ventricle, and one that they thread over to the left side of the heart, into the left ventricle. And this one helps kind of synchronize the heart function a little bit more. So it helps to improve the way that the heart is coordinated, because when the heart is most coordinated, and beats in that predictable coordinated manner, it's actually the most efficient as well. So if someone were to need also additional help with making sure that their cardiac output or the amount of blood that their heart's pushing forward is adequate, they may choose this for them. So again, the heart rhythm doctor is the one who will ultimately make the choice as to which of these devices is the best, but there are a couple different lead placements and things that they have to consider when they choose to put in a pacemaker. So in addition to pacemakers, there's a very similar yet different device called an ICD, or an implantable cardioverter defibrillator. Some devices are both a pacemaker and an ICD together, so it's possible that someone has one of those little disc generator devices in their chest, but it performs both pacemaker and ICD functions. Some devices are just ICDs and some are just pacemakers. So it really will depend on the person and what they have going on, and what the doctor feels like they need. So the purpose of these ones, as opposed to the pacemakers that are kind of set maybe to make the patient's heart beat 80 times a minute, 60 times a minute, whatever, the ICD is set more to treat potentially fatal ventricular arrhythmias. We know that certain people are at risk more of having these. They're called ventricular tachycardia, which is abbreviated VT, or ventricular fibrillation, which is abbreviated VF. And both of these are problems that could possibly cause a cardiac arrest. And what we know is that if someone has a cardiac arrest that's outside the hospital, there's a high risk that could prove fatal. About 10% of people survive an out-of-hospital cardiac arrest. So this is one thing that doctors came up with to try to help increase people's survival from these abnormal heart rhythms, because it'll actually help get the person out of those dangerous rhythms. So these ones, as opposed to monitoring the heart rhythm and making sure it doesn't fall below a certain point, which is kind of what a pacemaker does, this one is more set up to detect these abnormal rhythms. So it records the heart's activity, and then it'll deliver a treatment for the VT or the VF. The whole device setup is pretty similar in that it has that generator and then the leads that go into the heart. The main difference that you see with this one is on the right-hand side on the bottom of the lead, and granted, this is a cartoon, so it's kind of just a drawing, but it's a little thicker on the bottom, and that's because this device has what's called a defibrillation coil, and so that allows you to deliver a little bit more energy to the heart to help try to get it out of this rhythm. So there are three ways that it can treat ventricular fib or tachycardia. The first one is something called anti-tachycardia pacing. And so that one, the defibrillator will try to deliver a burst of really fast shocks to the heart. Generally, someone may not feel this other than like a palpitation in their chest, to try to override the abnormal heart rhythm that's happening and try to restore the regular rhythm. So that's shown by that first picture on the top. The second one that it can do is what's called a cardioversion shock, which is very similar to the defibrillation shock. Basically, it's just the amount of energy and the synchronization to the heart's rhythm that differs between the both of them. But basically what those two are doing is it's delivering a very strong shock to the heart muscle to try to shock it out of that bad heart rhythm. And so if you think about, if any of you's ever taken like a CPR class or anything like that, and they talk about the automated external defibrillator, the AED, you've probably been to like a sports stadium and seen like AED on the wall or whatever, where it's located in the venue. And so this performs when it does the shock, it does basically what an AED would do if someone were to have an arrest and, you were to apply the pads as you were helping the person, is it can identify what's happening and then deliver a shock. And so the reason that this is helpful is that if a person, is not around anyone or doesn't notice that their heart's going to this rhythm or starts feeling really bad and they're in this rhythm, or they're just plain out not in the hospital and we're not monitoring you and you go into this rhythm, then it helps kind of get the person out of that rhythm so that they can seek further help. Um, so there are patients, like I said, who are at high risk for a cardiac arrest. This could be someone who has one or more episodes of spontaneous sustained VT or VF without a reversible cause. So meaning that there's no reason that we found that, we treat it, it's better. And then they also have like an algorithm. There's several of them that exist out there, but people at high risk for either of these rhythms that they calculate through a combination of risk factors. And this combination can include a history of a previous heart attack, a severely reduced heart function. So that's that ejection fraction number or the amount of blood that's squeezed out of the heart. So if that number is less than 35%, a cardiomyopathy, congenital heart disease, which is something that someone's born with, or advanced heart failure, which is again getting at that reduced heart function. Again, not one of these things is 100% like that person should have an ICD, but the doctor will use an algorithm to determine whether a constellation of these things may qualify someone for possibly benefiting from having an ICD implanted. There's another component. So obviously we've been talking a lot about, sudden cardiac death and all that. It's, heavy stuff. So it's important to address the mental health aspect of ICDs and what goes on for these people who have them. So for people who have ICD, about half to a third of them will receive a shock in the first year after implantation. The sensation, granted, I don't have an ICD, so I can't speak to one, but I had a nursing student one time who we were talking, we had seen patients on the floor and he was like, or I was like, oh, do you know what an ICD is? He's like, oh my goodness, like I actually have one. And so he and I were talking about it a little bit and they're about like the mental health consequences in journal articles and also just from that conversation with him, people have said that it feels like kind of like a swift kick in the chest. Apparently they polled people and people rated that it was like a 6 out of 10 on the pain scale, but obviously pain's subjective and everybody is different. Interestingly, they did some quality of life research that indicates that having an ICD is at least equal to or better than having antiarrhythmic medicines on most quality of life indicators, which I just thought was an interesting fact because, medications have side effect as well. And that's the other way that they would possibly treat these dangerous heart rhythms. And then unsurprisingly, 13 to 38% of people with an ICD do report significant levels of anxiety surrounding ICD shocks, device malfunction, or concerns of death. And so it's important that we think a little bit about mental health care as well post-shock. So obviously it's a good thing because it helps prevent you from that sudden cardiac death. However, it's scary. And so immediately afterwards, first check in with how you're feeling. Like, are you feeling okay in terms of like physically? Like, do you have any dizziness, lightheadedness, palpitations, anything to indicate that, maybe there's still a problem where the heart is in that rhythm? Or, do you feel fine? The thing that then you kind of want to do is kind of, take a moment, try to, I mean, easier said than done, right? Like try to relax and as much as possible. And then the next thing that they recommend is that you should debrief with your doctor. So not only make that appointment where you discuss, what happened and whether there's anything they need to modify in terms of medication or anything, but ask your doctor to talk about, like this is how I felt when it happened. This is, what do you suggest that I do in terms of like, do I need to modify something I'm doing? Even just like talking through those things can be helpful in determining, just how you respond to it. And then you also want to engage in rewarding activities. Obviously, one of these shocks for someone with an ICD could happen at any time. It's not really anything anyone does to make it happen or not happen. So you don't necessarily want to avoid things that you enjoy just because a shock may have occurred after a certain action. And so I think that's hopefully whereas like support groups with you, like you guys could step in with someone, you guys could share these experiences and talk a little bit about just like mental health care surrounding these things. So physically though, there are a couple things that people who have ICs should know. So anytime you receive a shock, a doctor needs to know. If you feel fine immediately after, you can call your cardiologist and discuss the event and arrange appropriate follow-ups. So that's just kind of like a doctor's visit if you feel fine afterwards. If you received a shock and you still feel chest pain, pressure, shortness of breath, rapid heart action, like those palpitations, feel dizzy, confused, or not well. So basically those arrhythmia symptoms that we were talking about earlier in the night, if you feel any of that, you want to seek medical attention immediately. And so that means either if you're near the hospital, go to the hospital, or call 911 and have someone bring you into the hospital. It's not something that you'd want to like drive yourself or anything like that. You'd want to make sure that you were brought in a safe manner by emergency medical services to the hospital. And then if you get 2 or more shocks within 24 hours, whether you feel fine or ill, you also want to go into the emergency room because that means that there's something happening that, the doctors should evaluate and figure out what's going on. Quickly, we'll just talk a little bit about how the device is put in. So we've already talked a little bit about the placement. The electrophysiologist puts it in. Typically, it's in this little pocket of skin and fat tissue below the clavicle. They advance the leads into the heart and then they secure them into the heart muscle. And then typically someone could expect to stay in the hospital at least overnight to make sure that the device is working properly. In terms of things afterwards for someone, the pacemaker status, like we were talking about earlier, is regularly checked or interrogated. Like I said, with modern pacemakers, oftentimes this is done remotely. The information that'll go to your doctor's office from that remote monitor is the type of heart rhythm, the pacemaker lead function, so how those wires are working, how often the pacemaker is being used, because not all pacemakers are used 100% of the time. If the person's heart rate is above whatever the set rate is, they may not like quote turn on. They just turn on when the heart rate falls below the threshold. It'll life is and if there's any abnormal heart rhythms. Also good to know is that the pulse generator has a lithium battery in it that lasts about 10 years or so, but how much it's being used can affect how long it lasts, but your doctor's office would keep track of that and they would schedule a generator exchange if they need to. The other thing to know about care and maintenance is something called electromagnetic interference. And so that's basically just how devices that function around us in our everyday life can interfere with the pacemaker function because it does use electricity and it picks up the electrical activity of the heart. And that's how it's making decisions about whether to pace or not pace. So cell phones with strong magnets for wireless charging, like a lot of the new iPhones that you can put on the wireless chargers, can possibly interfere with the pacemaker function. So doctors recommend that if you're using a phone, just hold it on the ear opposite the pacemaker device. So if the pacemaker is on the left side, then just use your right hand to hold your phone. And then keep your phone when you're not using it in a pocket or a bag below your waist when it's not in use. So like a breast pocket in a like a men's button-up shirt is kind of what I'm thinking about. Is not a place you'd want to store it. Metal detectors like those used at the airport, they'll give you a card that says you have a pacemaker when you have one put in. You want to carry it with you in your wallet or on your person. It says that possibly it could be insignificant, the amount of interference, but airport personnel will likely prefer to do a manual security check for you, just due to any risk of interference. For someone who works in welding or with strong motor generator systems, they would want to just have a conversation with their doctor about their workplace because those could possibly interfere with the pacemaker. And then probably most importantly, if you're going to have any sort of surgery or a test, specifically an MRI, you want to let your doctor know prior. I guess hint for my myth busting in the future, you can get MRIs, but they have to change a couple of the settings. So you want to make sure that whoever would do any surgery or test knows that you have a pacemaker, even if you don't think it's going to be relevant or, always speak up, always let them know, because you want to make sure that your doctor knows because in case they have to reach out to a cardiologist to make sure that your pacemaker is set. So that's something really important if you have one. The newest advance in pacemaker technology, we've talked a lot about these pacemakers that have the big generator and the leads and stuff, but the newest thing is these leadless pacemakers. And so these were approved in the US by the FDA in 2016. Currently Medtronic makes it. It's called the micro transcatheter pacing system. So as you can see, it's in the palm of the person's hand. That's the whole thing. There's no leads, no nothing. No, it weighs in at 1/10 of an ounce, so it's super, super light. They insert it via a catheter in the leg and they advance it to the heart, so there's no incision. Typically the battery in this one lasts about 12 years. The main thing is that this is not appropriate for all people who would need a pacemaker. It's not used for all heart rhythm problems. So if anybody would need like any of the heart rhythm therapies that would help with the synchronization of the heart, this one is only going to sit in the right ventricle. So it's only going to be a single lead pacemaker basically. So it's only going to pace that ventricle. So if someone would need help coordinating the beat of the heart, to help with like heart failure symptoms, or if they were in persistent atrial fibrillation and it could not be corrected, or they didn't have plans to correct it, that's one thing that kind of this thing is not currently approved or indicated for. So again, this would be something that the doctor would make a decision about. But I mean, for people who can get it, it's great because there's no incision, and it's super tiny. So that is the newest thing in pacemakers. And that's just a picture of where it sits in the heart. So we're talking about how it sits in the right ventricle. It's literally just that, nothing on the chest, no incision, no nothing. All right, our last like fun little thing. So a couple myths. I feel like pop culture has, about pacemakers and things you can and can't do. So the first thing I feel like we hear all the time is that you can't use a microwave. You got to stay super far away from the microwave if you have a pacemaker. And this one's actually not true. The pacemaker manufacturers, they don't recommend any special precautions when using household appliances. So microwaves, TVs, radios, toasters, electric blankets, enjoy, use them, have fun. The other myth is that you can't go through anti-theft systems. So like when you're walking out of Target and they have the little like shoplifting devices, so not necessarily like metal detectors in the airport because they're slightly stronger, but interference technically is possible with them. It's unlikely to be significant unless you're around it for a prolonged period of time. So just walk in and out of the store at a normal pace. Just don't like lean on it or stay around it for a super long time. It's not your best friend. Just keep walking. That's basically all there is to say. And then the last myth really is that you can't get an MRI if you have a pacemaker. And so an MRI is significant because that is a big magnet. And so we always tell people before they get an MRI, if you have any metal in your body, that we make them go through this really long checklist that has, have you ever had like any like joint replacements, any sort of metal like in their body. And so you think, oh, that pacemaker is like probably made out of metal. You should always let your doctor know if you have a pacemaker, if surgery is being considered, like we said, but modern pacemakers are MRI safe. So the magnet's not going to pull anything, move anything from a metal perspective, but it may require special programming from your cardiologist prior to having your scan. When I've been working in the hospital, I've had to take several patients with pacemakers down to an MRI. And typically the cardiologist will, prescribe or put it in a certain MRI safe mode that they'll be on for the duration of the scan. And then after the scan, they'll come back with a programmer. And this programming device is just something that it's like a little computer that's attached to like a little monitor thing that gets put over the pacemaker on the patient's chest. And then they'll reprogram it using that because it's all computer data, electrical information. They'll reprogram it afterwards. So it's important that you let your doctor know because they may need to make these changes, but they'll put it right back to what it was beforehand after the test. So that is all that I have. If anybody has any questions, I also have, I can maybe send this to Karen, but I have, if people are want more information, there are a couple articles that I referenced when I was preparing the slides that are all, patient information, but a little bit beyond the basics. So if you have interest, maybe send these articles over to Karen so she can send them out to you guys.
Sounds good. I'd be happy to get them to whoever wanted them. I see a couple questions in the chat. First question is, can a pacemaker slow the heart rate down?
Yeah, that's a great question. So typically, no, pacemakers are not meant to slow the heart rate. They are going to be set at usually a range. So the ones that we have on, outpatient basis, meaning people outside the hospital, are going to have a rate setting. So usually like a minimum to a maximum. For example, maybe it will be fully automatic to pace the patient's heart at a rate like greater than 60 beats a minute to like 120. It can be responsive to your heart rate. So there's something called a rate response technology where it can actually sense the need for a higher heart rate. So for example, if you're like going on a walk or something and your body's consuming more energy and seems to want to go a little faster, sometimes they have this rate response technology built in that can actually elevate the heart rate a little bit below the minimum setting. But in general, it's not going to slow it down. The ICD, on the other hand, is going to slow the heart rate because those arrhythmias that I was talking about, the ventricular tachycardia and the ventricular fibrillation, are both very fast heart rhythms, where they're going to occur greater than 100 beats per minute. Sometimes, honestly, I've seen even greater than 200 beats per minute in my clinical experience, which is just super fast. And so ideally, any of those therapies that the ICD would deliver would return someone to a normal heart rate somewhere between, or excuse me, 60 to 100. So that will slow the heart rate, but it's also it's called converting it out of that abnormal heart rhythm into a normal heart rhythm again. But yeah, pacemakers don't typically slow the heart rate. They usually just increase it.
So if you're someone who chronically has a high heart rate,
Mhm.
a pacemaker is not going to help you pace at sort of a better rate.
Like a lower rate.
Correct.
Yeah, no. So the pacemaker is really meant for people who have too slow of a heart rate that needs to be brought up.
So my guess is in that scenario with the high heart rate, my guess is the discussion would be probably medications that could drop you into a better range.
Yeah. So I was talking on my one slide said certain medications can alter the heart rate that can cause, lower heart rates. A very common one that a lot of heart patients are on is called like beta blockers. So if someone's on like metoprolol or carvedilol, those are two that are really commonly prescribed. And so those ones actually decrease the heart rate typically. So it's important that your doctor would know like what your resting heart rate is prior to prescribing those medications for you, because sometimes they're not always prescribed for heart rate, although that is one thing that they're given for. Sometimes they can also be given for like heart failure symptoms. So it's important that they would know what your resting heart rate is prior to those medications being prescribed because they can actually lower heart rate.
Got it. The next couple questions are actually from me. I'm on my second pacemaker at this point, so I'm about 10 years into being paced with the device. I'm curious about the ICD portion, something that you said. I'm just curious when the ICD kicks in and gives you a shock,
Mhm.
is that transmitted directly to your EP's office? Like, do they get sort of a warning or signal that, say Karen's ICD went off at 8 p.m. on Tuesday night or whatever? Is that transmitted?
Yeah, so generally, from what I understand, no, they wouldn't get like a direct report. However, say, you had the shock, you call the doctor, or you come into the ER. In the ER, they're going to do what's called interrogating the device. And so they'll put that monitor on the chest over the device and they'll take a look, okay, like how many times did you get shocked? At what time was it? They'll be able to actually see, because it records the heart rhythm as well. They'll see what was the rhythm that sent you into this, to decide that it needed to be um, to make sure that it was an appropriately delivered shock. The device actually knew what was going on. But no, unfortunately, it's not going to like give them like a little email that says, this happened at this time, go check on them. So that's why it's important that, if you do get shocked, you need to call your doctor's office and let them know. And then if you don't feel good, definitely go to the hospital.
And then I'm curious about the leadless pacemaker. You
Mhm.
said it has like a shelf life, if you will, of 10 to 12 years. What happens when that battery dies? Does it have to be extracted and then another one replaced, or what happens sort of on the next go around?
Yeah, I mean, to be honest, so it was approved in 2016. It's only 2024.
Oh, so
So I have not really encountered very many patients who have needed a replacement of the Micra. I don't know how many, I'm sure they've had people who've had issues with them because, things happen. But that really, honestly, I would have to ask our EP docs because I have not actually run into that in my clinical practice. Just because I think we're not enough years out of these devices being implanted to the point where we've actually reached the first like routine exchange.
No, I read something where they, they're small enough and they can just kind of drop another one into the chamber. But if
Yeah.
someone's getting a leadless pacemaker in their 40s and God willing, they're going to live to their 70s,
Yeah.
how many of those little devices can you have in your chambers? It's
Yeah.
fascinating.
Yeah. I know that they can do like if you have a traditional pacemaker, if there's an issue with any sort of like infection or the lead doesn't work, they can actually extract a lead.
I just did
Um,
that.
oh,
Yeah.
you have that. Gotcha. Yeah, I think you told me that when we were planning this.
So I had atrial impedance. So at
Mm,
dual chamber pacemaker, I actually had to have both leads taken out with laser
mm,
and then everything put back in. So
gotcha.
it went
So
well.
this is the second one.
Grateful and just always amazed by the science. Anybody else have any questions? I don't see anything else in the chat, but we can certainly open it up and just have a conversation.
I got a quick
Go ahead,
question.
Brian.
So to get a pacemaker, is that an in and out type surgery, or are you required to stay in the hospital for a few days?
Typically, it's just a one overnight, like a 24 hours in the hospital. The reason that they want you to stay in the hospital is that they want to make sure that the device is working and that there is no bleeding from the site itself. Because very rarely I've seen where someone can get like a collection of blood under the skin, actually at the pacemaker site. So there are a couple things that they monitor for. And then typically someone from the device representative will come in the next morning from like the company who manufactures the device and they'll do the first interrogation. So meaning they'll look at, how much was it used overnight? Is it sensing the heart rhythm properly? Is it pacing properly? Because we don't want to send someone home without knowing that it's working well. And so typically someone would be admitted to like a cardiology floor. So like no intensive care unit, nothing like that. But you would just be on the floor with a heart monitor on overnight just to make sure that we're seeing, the pacing happen isn't slowing below the point that it's supposed to. So typically it's like a overnight in the hospital.
Is
Go
it
ahead.
customary to get it said the battery life is what, about 10 years?
Mhm.
So every 10 years you have to get an upgrade, or is it a battery change, or how does that work?
Yeah, so it's like on average about every 10 years. So like I said, the rate at which someone's using their pacemaker may determine whether that's sooner or later, because it'll also sense the patient's heart rate. So, for example, like you're only using it 50% of the time, it may last longer than that 10 years. If someone's using it 100% of the time, maybe it's closer to that 10 years. Um, what they would schedule you for when they do those, so basically what they're going to do is you'll send the information to the doctor's office when it gets to a certain point, and I don't know that exact cutoff because I don't work in the EP clinic, which is the place that does these procedures. But when you get to a certain cutoff, basically they'll schedule for a generator exchange. So they generally won't exchange the leads necessarily if they have to, because the hope with the leads is that they, when they're kind of affixed to the heart wall, scar tissue will form and hold the pacemaker leads into the heart wall. And so that's super important to make sure that it keeps pacing, but also we don't generally remove them because removing it from the scar tissue can cause damage to the heart muscle. And so usually they won't replace the whole entire thing unless there's some reason to mess with the leads. Usually they'll just replace that little disc, that generator that's the computer and the battery.
Does a stent affect a pacemaker?
Yeah, that's a good question. So a stent and a pacemaker would be in two separate locations in the heart. The
Okay.
pacemaker is kind of internally threaded through the inside of the heart where the blood is pumping. A stent is usually in one of the coronary arteries. So those, when the blood exits the last chamber of the heart, the left ventricle, there's little arteries that kind of feed the heart itself. The heart feeds itself first. And so it is located usually in one of those arteries. Kind of, you can think it's still like part of the heart. And I don't want to say on the outside of the heart because it's still technically part of the heart structure, but it's not in the same part where the blood is being pumped. It's kind of the first small blood vessels that actually feed the heart itself. And it's kind of sits on the outside of the heart, but it's still part of the heart. So all that to say, the pacemaker goes in through a vein. A stent would be placed in an artery, and those two systems are they're separate. So,
Thank you. Okay, well, folks, if that we don't have any more questions, we're going to go ahead and end. And again, our new people, thank you for joining us. I hope that it was informative, and hope to see you all again.